I'd like to take a moment to introduce our panel. We have really a fantastic panel today on Ebola virus. So I'm going to start by introducing Art Reingold, who's a professor at the School of Public Health, the Associate Dean for Research in the School of Public Health. And he has sort of the broad overview. So he's going to open up with a few remarks about what's going on now with Ebola, what's happened and what's going on now. But mostly this is going to be interactive, so we want to hear your questions about what it's like working with it. Dana Clutter is a physician. She's an ID fellow at Stanford, and she's actually worked with Ebola patients in Sierra Leone. And you can see these slides are from Jana Broadhurst and Dana, their experiences over there in Sierra Leone. So Jana Broadhurst is going into her pathology residency. She is an MD PhD graduate from UCSF. And she also worked in Sierra Leone, but not directly with the patients so much as trying to figure out how do you make lab diagnostics work for Ebola patients. Because really important in Ebola is identifying the patients, and how do we do that in a rapid manner. So along those lines, we have David Persing here, the Chief Medical Officer, or Medical and Technology Officer, Executive Vice President of Cepheid, which is a company that's done a lot for diagnostics in Africa. So we're going to hear his perspective at more the global level. So with that brief introduction, I think I'd like to turn it over to Art for just a few minutes to tell us what's going on now, and then we're going to move to questions from the crowd.
Okay, thanks, Phil. So good afternoon, everyone. I'll keep my remarks very brief. One of the good things is that anyone can go online and look at the WHO website and be completely up to date. So I don't have any data that you couldn't readily go online and find. I think everyone in the room knows that this Ebola outbreak is unprecedented. It's now been going on for over 18 months, having started really in December of 2013 in terms of the first cases. We're now at over 27,000 cases and 11,000 deaths, virtually all of them in three desperately poor countries in West Africa: Guinea, Sierra Leone, and Liberia. I think most people know that we've now been without any additional cases in Liberia now for a number of weeks, so the outbreak does seem to have been extinguished in Liberia, but within the most recent 1 week period, we've had 9 cases in Guinea and 3 cases in Sierra Leone. So there continue to be cases in at least 2 of the 3 countries, but markedly diminished in number. The primary ways in which people have been acquiring the infection through patient care and through unsafe burial practices are largely under control through the work of epidemiologists and public health officials and clinicians. And you'll hear some of that from people who've been on the ground working in those countries. I think if you ask what are some of the pressing questions of the day that we might want to talk about, obviously on the scientific end, one is how well are the vaccines that people are currently trying to study in the field going to work. It's probably too late to test their efficacy, but we'll certainly learn something about their immunogenicity and their safety. Some lingering questions about sexual transmission of this virus and whether people who are infected, even once they've recovered, can sexually transmit the virus to their partners, as well as a number of other sort of interesting scientific questions. But from a public health and policy point of view, the $64 question is, how do we make sure that something of this magnitude never happens again? What were the failings of the global health infrastructure of the World Health Organization, of other structures that allowed this epidemic to go out of control and continue for 18 months? And what realistically can be done to put structures in place to make sure it never happens again? So I'm going to just leave it at that, because I'm sure that there are lots of things we can talk about based on that.
Perfect. So do we have any questions from the field, from the audience? I have a number I want to ask here, but is there anybody who wants to jump in with a question early? Okay, I know it's intimidating to ask questions. So I'm going to start then. And I think this one will be really for Jana and Dana, and I'll start with you, Dana. What were you thinking? You went over there and worked in this outbreak, and we see some of the conditions up here on the screen, but really, so what was it that drew you to do this? And were you afraid, and how did you deal with that? And Tell us about that.
Yeah. So it was a tough decision. Obviously, there was certainly risk that had to be considered, but I just felt myself kind of just really compelled to go. I couldn't stop, watching the news about it, reading the situation reports every day, and just feeling like, although I'm still training in infectious diseases, I'm, certified in internal medicine. That's really what this required, was just being able to give fluids, identify someone who is sick. So I felt like, I can definitely do this. And, I was fortunately at a point in my training where I had relatively light clinical responsibility. So it was relatively easy for me to take off in that regard. So I kind of just felt like if not me, then who, So that's kind of why I went. Yeah.
Just would like to follow up on that because of a travel memo Stanford sent to faculty, whether you could comment on that, which effectively said that their researchers were limited in terms of helping anybody who chose to travel from Stanford and became infected, and how that influenced your thinking, or how, in fact, what the Stanford reaction was.
Right. So they did make it clear that the choice to go would definitely be a personal one, and Stanford wasn't, sending physicians from, from Stanford at the time. You kind of had to take your personal time to go and do that. But if you chose to do that, then they were supportive of doing so. So that's how I did it. It was kind of separate from Stanford.
Hi. I was going to ask David, because we talked about this, I think, in January with a colleague that was on the ground in Sierra Leone. We had that conference call. And what struck me was, I'm asking you how Cepheid or any company would balance the the need that Dan Kelly was expressing to us on the phone to have things now in the field, not in the clinic or the hospital. And Cepheid being an FDA-approved company, commercial company, how do you strike that balance of, getting things obviously through regulation and approval versus an emergency situation on the ground?
Yeah, it was a challenge. The company already had and has a large footprint of systems out there, mostly for the TB testing space, because our TB test is commonly used in Africa. So we had a lot of requests to do something about it, and in fact got approached by the Gates Foundation and the Allen Family Foundation to jointly support test development, but they really wanted it quickly. And so we said, well, we just developed the HIV test. We can leverage that information. We can potentially apply that to Ebola. And we defined the specs, and they funded it within 2 weeks of submitting the proposal to them. And they really provided the support that we needed to make it happen, to hire the people, to bring them on, to develop the product. We did not want to derail our pipeline of other products in development to do this, because it was, we're still I guess you call it an emerging company, not yet an established company. So it was, all that came together, and we were able to do it very quickly and get through both the FDA emergency use authorization with a 2-week review process there, and the WHO authorization for procurement within about a 4-week process of review. All those have happened in the past 4 months. So now, just in time for the epidemic to be almost gone. And that's part of the challenge, is that you do something, even 4 months is not fast enough to meet the need on the ground as it was in January. Having said that, I think the technology is now well positioned to be able to serve an important role for keeping the epidemic under control, because we have now a variety of diagnostic and surveillance technologies which are available that didn't exist a year ago. And those are going to be used not just for managing the rising part of the epidemic, but managing the surveillance activities that need to go on for a while to really have it under control. This all started with one case, and it could easily start again. So, and I'm sure that Jana will have something to say about that, but right now they're really concerned about identifying cases of infection among any number of possible causes of death, especially in febrile patients, of which there are a lot of possible causes, and to identify the ones that are of great public health significance that represent transmission risk is the big challenge right now. So that's where these technologies are going to come into play. And hopefully we'll see wider adoption of them, and I think they'll be used for the next several years until we are totally confident that the cases are gone, and be ready for readiness the next time they hit.
Along those lines, I guess and the idea of the postmortem around what's happened since. I've been kind of curious because of the challenge of ramping up not only new technologies, but treatments and their potential therapeutics. It's clear that these sort of emerging infectious agents are happening and going to happen. And there have been a number of novel regulatory approaches that have been utilized in this outbreak. But I'm curious if either of you can comment on, kind of as we're thinking about the next outbreak, things that can be done both on the policy and infrastructure side or that are in progress. And also, from your perspective on the industry side about how to ramp up and be more nimble to be able to address these outbreaks in more of a real-time manner. It's a big question.
So let me just make one comment in response to just one piece of what you're saying. For example, many people pointed out that we've obviously known about the Ebola virus for 30 years, 40 years. Why didn't we have a vaccine already on the shelf? Why did it have to be developed quickly as opposed to work already having been done on that? And of course, there had been some work. And you could ask the question, why didn't people go further ahead and develop it further? And I think in one sense, the standard answer is, well, it wasn't going to make anybody much money and all of that. But I think there's actually a more complicated answer to that. And I know there are people involved in viral discovery. There are lots of interesting viruses in animals in different parts of the world. But most of my day job is spent trying to get people to accept measles vaccine and try to accept pertussis vaccine and vaccines against diseases that we know are a serious threat to people and where people have their doubts about safety and need and whatever. And for me, the idea that you would develop vaccines against Lassa and Ebola and 40 other things just in case, when the cost is enormous, when you can't really test efficacy, absent disease. It's really an interesting question. How do we get to having vaccines for these infections just in case? I think it's a really complicated policy question. It's not just a scientific one.
So I want to ask Jana a question. So as we're thinking about how to get involved in this, some of these people in the audience might want to be involved in, sort of the hot zone research. So as a physician, you can clearly volunteer for things like Doctors Without Borders or Partners in Health. But how did you get involved on a science project, I think? Can you tell us a little bit about what you did over there and how, because it all happened pretty quickly, I think. So how did you manage to go from being where you were to being over there?
Yeah, I'll start with just a very brief background about how I got involved. I did actually start out in a pretty similar position to Dana, although with much less clinical experience at the time. I felt very compelled to get involved and was willing to get involved on a clinical level. Luckily, when I connected with Partners in Health as an organization, at that point in the crisis, it had become pretty clear that the long turnaround time in diagnosing Ebola was a major driver of the epidemic, and that people needed to get in the game who were really wanting to, spearhead efforts to figure out this diagnostic dilemma. And so I did join Partners in Health in that role. And early on, that meant really trying to break down the problem of why is it taking 7 days to diagnose Ebola. In that time frame, you can imagine if a patient came in, with some other febrile illness and was in an isolation ward for several days in close proximity to other Ebola patients, their chances of contracting the virus were high. So this was a problem on kind of every level of isolation and treatment efforts. And that turned out to be not surprisingly, a multifaceted problem, and it started with challenges around just collecting venipuncture blood for diagnosis, transporting that blood to a laboratory that had the technology to do real-time PCR, and then managing to integrate those results back into case management, and with communication issues and complicated patient identification schemes. This was a nearly untenable system. And so I was there for already a few months before kind of novel diagnostic technologies had come far enough along to be ready for field testing. And so we were all very, very eager to move those projects forward. And I think so from my position, it was coming from already being pretty entrenched in the response. But I worked with several folks from the academic sector who were kind of coming in, specifically on a research role, and that could be for developing for vaccines, therapeutics, or diagnostics. And I think it was interesting to see that evolve. Certainly from the academic sector, there's this clarity in formulating the research question and understanding the rigorous methodology that you need to get reliable results. But there's very little else. So there's a big need to identify clinical partners, of course, to have access to samples, and laboratory partners to house your analytics, and then logistical partners so that you can bring in your supplies and transport them and maintain cold chains and all of the operational considerations. And so those partnerships evolved, and they evolved quickly. And so I think that there were great opportunities for researchers to come in from academic institutions and do some meaningful work. I think where the biggest problem, one of the main challenges there was in a setting like this. I know this is obvious to say, but in such a high risk and minimal resource setting, any duplication of efforts is really it's not acceptable, right? You're really taxing the system unnecessarily if multiple people are pursuing the same types of research questions and not talking to each other and not coordinating. And so I think the transparency among multiple research groups is always it's always a challenge, but in an outbreak setting, it's really an imperative.
Hi, I'm curious about the decline of cases, decrease of cases over the last few months and or since the peak. And was that pure luck? Was that seasonal? Was that education of the people? Was that isolation of those infected? Was it all of the above? And how will that affect maybe future outbreaks, like if it is increased education?
The clinicians may want to say something about it from a clinical point of view, being on the ground there, but I would say two things about that. First of all, epidemiologically, from a public health and prevention point of view, it's been known for a long time how to prevent transmission of this virus. And so it was really just application of two things. One is making sure that people taking care of sick people did not become infected, and that people caring for dead bodies and burying dead bodies did not become infected. And so the real challenges there are that delivering good clinical care to patients in a very difficult setting and not becoming infected requires a certain level of equipment and materials and personal attention that are not easy to come by, and that the safe burial piece bumps up against some very, very long-standing cultural norms in which washing the body, caring for the body, touching the body is deeply ingrained in the culture. So it really took a great deal of engagement with the community and really trying to make people understand that they really had to change their practices in order to be safe and to protect themselves. But in essence, it was doing something that people have been known since 1976, how to prevent the transmission of this virus. So I don't think it was luck, and I don't think it was seasonality. It was applying pretty standard infection control techniques. But
I think one thing that was really important was for community engagement, and I think that took a little bit of time. And I think one thing that was really important for that to happen, for people to report symptoms early, to be willing to come into an Ebola treatment center, was for good care to be happening in the treatment centers. And I think once people realized that you could go in, you could get treatment, you could survive, people were more willing to come in. And so one thing that we witnessed in our Ebola treatment unit was people who pretty clearly did not have Ebola would even come in just because or try to come in because they knew this was a place where you could get health care. So I just think that the community knowing that the Ebola treatment unit is a place that you can get care, I think was important and did happen kind of later in the epidemic. But I think it's definitely a multifactorial effect of why we saw the cases drop off.
I probably shouldn't say this, but it was reported in the New York Times that one of the people leading the efforts to develop an Ebola vaccine at a national institution I won't name was quoted as having said, "What is this community engagement business?" And this was somebody who clearly knew an awful lot about immunology and virology, but community engagement is actually reasonably important when it comes to getting people to change their behaviors.
Just add on to that I think this was of course, an unprecedented scenario, and it was an iterative process of everybody figuring out how to do their jobs well. And one of the sort of superstructures of the response is this pillared system, and those pillars existed sort of within the government aspect of the response, as well as within the military aspect and the more regulatory body, as in WHO aspect of the response. Everyone sort of, trended towards this kind of organization of the response, and those pillars included case management and surveillance. More traditional and expected aspects, but social mobilization also became one of the main pillars of the response. And that I think really speaks to this realization that community outreach and messaging and education was so critical. And I think I would also say along the lines of this iterative process, and this would just be speaking from my experience in Sierra Leone. I don't know how this played out in Guinea or Liberia, but I think there was a lot of players in the game early on who were trying to kind of play a role in each step in the continuum of deciding what to do and doing it. And what evolved over 12 to 18 months was realizing that some people were better at some parts of that continuum than others. That there should be policymakers and regulators, there's funders and suppliers, and then there's implementers. And people really started to, I think, take accountability and responsibility for those more specific types of roles. And I hope that that's something that is a learning point that the community takes away from this response, because it really made a huge difference on the very local level and district level and national level when those pieces fell into place.
Toward the goal of preventing the next outbreak, I know I have some awareness that there are efforts underway to build and expand the infrastructure that's lost and needed in these areas. But I also sort of wonder what the plan is for the human capital side of it. I don't think the healthcare professionals are as plentiful as needed. Is that going to be an issue in the future? And if so, do you know what's being thought of or done in that regard?
I don't know if anyone else wants to speak to this. In terms of transitioning out of the crisis response and into a more health system strengthening type of effort, certainly the training and retention of clinicians is a part of that. I think that training and retention of clinicians and also integrating the laboratory resources that have been infused into the region as part of the response, and then just the basic infrastructure building. All of those are certainly being thought about carefully, and they're all, of course, very challenging. I think that there has to be good hospitals for clinicians to train in if you're going to train them well and retain them. So that is probably the lowest hanging fruit that will be addressed most immediately is just facilities and infrastructure. I don't know if that gets to your question at all.
So I think clearly there's both the clinical piece and healthcare providers who are desperately needed and are going to, if they can't be imported, and they clearly can't be imported on an ongoing basis, the capacity needs to be developed to train nurses, doctors, other types of healthcare providers in substantial numbers. But in addition, the public health capacity for surveillance and outbreak detection and response is a piece where obviously external partners can and will be responsible for quite a bit of that. But many of you may know that under the president's current budget, there's something in the order of $1 billion for global health security, which is money going through CDC to build these capacities in a large number of countries around the world. It's going to be a very long-term process, and these countries are certainly going to be part of that building of global health security infrastructure.
We hear about various individuals who are involved in the media. I was recently at the CDC, and one of the things that surprised me greatly is they said that there were over 1,000 CDC workers, something under 400 people on the ground, including most of the EAS class. The magnitude of the response, which we really haven't heard about, and that's just for CDC. Can you give us some idea of what the full magnitude of this response was in terms of the number of people that were deployed, Médecins Sans Frontières? And by the way, the CDC had very little presence in Guinea, apparently just because of language barriers.
I don't know the actual number of the responders. In guessing with friends, we thought there was probably something on the order of 10,000. And these people have various types of presence. Of course, it's one of the reasons it's hard to estimate. CDC, for example, doing incredible work in the field, but no one working for the CDC was allowed to enter a red zone. So you could be a clinician treating Ebola patients all day and never have any idea that the CDC was present. So there was substantial segregation of these different agencies who were involved. Similarly, most of those coming from the WHO were also restricted from entering the red zone. And that delineation was unfortunate. There wasn't, I think it really limited the type of understanding and communication that happened between the different agencies involved. And even on a clinical level, the different NGOs involved, there's Doctors Without Borders and Partners in Health and GOAL and UNICEF, Save the Children, a lot of people doing incredible clinical work. But I think, understandably, because of the high risks and stakes involved, each organization also was fairly siloed within their treatment units and had their ways of operating. And so there was even very little communication between clinical NGOs, and I think consequently there was an unfortunate limitation in what we could learn from each other and our experiences because of that kind of siloed nature. So yeah, overall magnitude of the response, I'm sure was on the order of tens of thousands, but everyone's effort didn't necessarily benefit from that magnitude because of the isolation of each agency.
I think it's worth pointing out, I think everyone knows, but not only was there involvement by the United States, including the U.S. military, but clearly there were substantial numbers of people from Cuba, from China, from the UK. I mean, this was clearly a global effort involving many, many countries. And I think the total numbers, if you include all those people, are certainly in the tens of thousands.
Thank you for everything you've done to confront this outbreak. Following up on lessons learned, you started to mention the siloed approach. What other lessons did you learn there? What would you do differently in country? For example, the United States came in and built fixed hospitals. I mean, the military was really tremendous in terms of building hospitals, but in fact, the epidemic was moving to different areas and suddenly the hospital was empty. Would a better approach be to create mobile units that could move to where the epidemic was moving? And then here at home in the United States, I mean, the CDC says every American hospital is fully capable of confronting this pathogen. Clearly that is not the case. What's the lesson that we've learned here in terms of the next big pathogen outbreak that might come to these shores? What's different? So I just kind of throw that out to the panel. Lessons learned there and lessons learned here.
I can comment a little bit about the mobile testing concept. There's a lot of interest in that right now because there's good demonstrations of mobile testing units, mobile management units that can be driven to places that are inaccessible or where an earlier response is necessary. We've seen good demonstrations of that with, for instance, our TB tests on mobile vans in South Africa, where they will drive into a site where there's a mine, and they'll bring up the miners for testing, and if they're positive for TB, they don't go back down in the mine until they're adequately managed and treated, and they move on to the next mine. And it's a good way to maximize the resource of having that mobile testing capability. The same concept is being looked at right now for Ebola, but one of the big concerns is with Ebola, is it safe to do that on a mobile testing unit? Are you safe to be able to run a test without exposing the lab workers to stuff during the testing process? So there are barriers that need to be considered in the process. The other part of it is you're getting all this information and test data being generated. How is that being communicated? Are we getting electronic data feeds from those sites according to a geopositioned result? So you know where and when it happened, and it gets fed up to a cloud-based monitoring system that can actually tell you where the action is in terms of new cases being identified. Those kinds of capacities really need to be built up in these countries. And of course, the communications in many of these countries is not great, and you have to really address the infrastructure aspects as well. But to really maximize that mobile test capability, you need tests that can be safely operated and for which the results can be generated and kicked up to the right level to get the attention of those involved to be able to provide a good first response in that setting.
I don't know the answer to your question in terms of mobile units and all of that. I think it's a really important question. I think one lesson learned domestically is I don't think the next time we have a situation like this that CDC will assume that a hospital in Dallas knows what to do with the patient. And leaving aside the federal, state, and local control issues, I think you're going to see a much more hands-on, assertive response from the federal government every time there's a case or suspected case anywhere. I think that's for sure.
And then I think just one other comment is, I think a lot of people, view the outbreak and its ability to kind of reach the extent that it did as just, a symptom of an incredibly weak healthcare systems. And so I think many feel that, the focus on rebuilding healthcare systems that were weak to begin with is kind of the key to, preventing something to getting as out of control as this current outbreak did. When you look at countries like Nigeria, Mali, Senegal, who were a little bit more prepared, had better diagnostic support, they were really able to curb it quick, whereas unfortunately it wasn't able to happen in these countries.
Okay, I have a question for Art, but anybody else should feel free to answer it. And that is, if the president had appointed you as the Ebola czar, would you have taken half the resources that went into this and diverted it to treating other diseases, particularly childhood diarrheal diseases? Or do you think it's justified to put all the resources that went into this one disease when so many young people in Africa are dying from so many other things? I mean, just as background to this, it seems to me that the West panicked when they felt that there was an outbreak that could be transported to us, and that our response actually is to be cynical, a rather selfish response, and there's a lot going on that we ignore. And maybe the Ebola crisis has diverted a lot of resources that we should put elsewhere into African healthcare.
That's an easy question. So first of all, I think everyone understands that beyond all of the illnesses and deaths caused by Ebola, there were many other deaths resulting from an inability to care for pregnant women with obstructed labor, to care for children with diarrhea, to care for the other more mundane things, because either the facilities were closed, the healthcare workers were ill themselves, or simply didn't exist. So it certainly had a knock-on effect much more broadly in terms of health outcomes. And so I think we always have this issue of how do we allocate scarce resources? Are we stealing from Peter to pay Paul? And I don't really know the answer to your question, but there's a great deal of exceptionalism that goes on, whether we're responding to HIV, whether we're responding to Ebola, where you could argue, if you're going to count DALYs, number of deaths averted, number of illnesses prevented, that it's not a rational allocation of funds. And I don't think it ever will be. It's emotional, it's political, and it's human. So I don't know the answer. I don't know if these guys do, but I don't.
I think the hope is that you can utilize those resources to improve the healthcare system across the board. And I think in a lot of cases that's true. There's a lot of resources that were infused into the region that will be applied to sustainable programs, at least attempted to be. So I think that's a little bit of a silver lining.
I was interested to hear more about the survivors. So obviously the response doesn't stop with just surviving or dying. We know that the survivors have long-term problems, not only psychological, but also persistence of the virus in the eye. So how has that changed the response? Are they monitored? Are they treated? How do we get rid of this remaining virus?
Yeah, this is certainly a clinical phenomenon that's known, but hasn't ever been of a large enough scale to develop programs around. I don't know if the question was heard by the group. It's a great one, which is what sort of monitoring or clinical programs are available to Ebola survivors, of which now there are of course many thousands who have survived the infection, and they do suffer both from sort of reservoirs of the virus as well as from post-viral inflammatory syndromes, severe long-term symptoms for years, including lots of aches and pains and muscles and joints. But probably one of the most concerning aspects of survivorship is inflammatory disease in the eye, which can often lead to blindness, and that's now been seen in many survivors and healthcare workers who have survived infection. So there is a big thrust of effort now to establish clinics that are primarily for survivors. Again, I think there's a recognition that not too much resources can be pulled away from other programs that have suffered in the face of the response. But a lot of it is education and community outreach again, but understanding how to actually understand the pathophysiology of the syndrome and address it. It's not easy, of course, and probably will involve, there's going to be a role for antivirals and a role for anti-inflammatories, and people are still figuring that out as we go. But yeah, there's a lot of attention being paid to it.
So I have a question for David. I want to dig a little deeper on this. When we talked about it, we alluded to it. I mean, so you're at a for-profit company, and you have a fiduciary responsibility to make a test that's going to make money. And I'd bet your Ebola test isn't going to sell as much as your TB test do, right? So how do you, and even though you got, it sounds like some resources from Gates, it took your time, it took some people's company time to divert away from the main thrust of what you're doing. So how do you balance this? I mean, I think there's, the moral, we should do this, but then there's also a real, you're sort of still in your ramp-up phase of a company. How do you decide to do that, and what was it for your company that allowed you to do this?
It's a good question. I think it sort of goes back to the original, my original days with the company in 2005 when they had their first meeting with FIND and the Gates Foundation about the TB test. And at that time there was, this is in 2005, and we hadn't started development of the TB test yet. And there were a lot of things that went into that decision to engage to do that. One of which was, it's a high visibility project for us. We're likely to succeed on this. We're likely to make a name for ourselves with this technology. At the same time, we're likely to benefit at the level of understanding more about our own technology, being able to develop a test that required a lot of first-in-class things that we hadn't done before. So we'd learn a lot along the way that could be leveraged across other programs and projects. And then the ability to justify and pay for, even though we're not selling the TB test at a profit, be able to pay for the manufacturing capability to scale that up. And really the whole scale-up manufacturing issue, multi-center manufacturing issue, which could then be leveraged to manufacture other products that were for-profit. It all came together, and the CEO had the vision that we should do this. And the same questions came up for Ebola, not so much because of the volumes that we'd be making, but because it was the right thing to do at the time. And we felt responsible to engage because we already had committed to making the platform technology available at a reduced cost in the so-called high-burden developing countries. As part of the TB program. So as part of that justification to the CEO, I had to say, I think we're going to be able to minimize the amount of distraction from our other programs by leveraging the so-called opium, other people's money, that that we would be getting from the Gates and Allen co-funded program. And we were quite successful in doing that because we were in active development for the HIV and HCV assays. At the time, we'd already done probably 90% of the development that went into the Ebola cartridge was already done by virtue of HIV and HCV. So we were able to make the argument that we would not spend a huge amount of time, resource, and distraction on Ebola. It did work out that way. So I think we've managed to get the product done in a time frame that's probably not ideal for what the epidemic. Back when we started, this was going to be going on for years, and we're going to be seeing millions of cases. And I don't think we expected to see it subside as quickly as we did, but I do think that we still have an opportunity to play a role in surveillance and for helping to identify the next sources of the outbreak, of the next outbreak that's going to happen. There's no question about it. And at the same time, we've got a footprint that will probably get larger because of this in terms of establishing technologies for other conditions that were already mentioned, other public health concerns, TB, HIV, cervical cancer screening, chlamydia, gonorrhea, the things that we have to struggle with in developing countries even more so than here.
Great, thank you. So, okay, one last question here, because I know we have flights to catch for some of our panelists. So I'll give you this, and then I will have the moderator's prerogative of the very last question, but here you go.
Thanks. Is it on? Yep. David, my question is for anyone on the panel, but I met your CEO a couple of years ago, and I watched him present a business model where he was talking about trying to go to single centers for cities where they would be a testing center and neighboring hospitals would send samples to this one center. So I didn't go on with my question, which you seem to have pushed with him, but the most interesting part of the technology to me for your company was the scalability. And I thought, wow, you can just keep putting these modules in, and it looked like a lot of modules could go in when at first there's just one. And so I thought, well, you know, the scale also has to go for the power. Right? I wondered why they weren't going in the opposite direction and making the testing or the diagnostics low power consumption, which is a big problem here, I think. I don't see a lot of centrifuges or electrophoresis equipment.
Well, one way to address it is to put it on mobile vans where a voltage converter can get you all the power that you need to run one of these systems, or most other diagnostic systems that are in this scale will be runnable on that kind of environment. The other, of course, is to make sure they have low power requirements, so you have solar power options and battery backup options that can run them as well. And we're seeing those being implemented in a variety of settings for testing. But I agree, there is a need for not so much centralized testing, but a combination of decentralized and centralized testing, because it's just a matter of, it all comes down to sample transport and sample stability. How long does it take to get a specimen across the country to the testing center, and is it going to be any good when it gets there for testing?
Can I just ask someone else on the panel then to go on and say, I thought the nucleic acids would be the best diagnostic. Is that true, or what would be an ideal diagnosis in a geography like that?
I actually think that there's not a perfect diagnostic tool that you could place across the board. I think that there's different settings, and you want to have some options available to you. So I think that for this and future outbreaks and similar outbreak settings, there's going to be this spectrum of centralized testing and an established national laboratory all the way to point-of-care testing at the bedside, right? And those tests are going to have different characteristics. They're going to differ in their biology, of course, whether or not they're detecting nucleic acid or protein. But they're also going to differ in their specifications and in terms of sensitivity and specificity. And all of those things matter differently depending on the prevalence, of the disease where you're testing it, the accessibility to, different gradations of technology and electricity and waste management and all the things that come along with lab infrastructure. So I think in my perspective, what I learned is that there's not actually an ideal tool, and that we need different options that are suitable for different settings. And some places there's a really long, bumpy road to that next even mobile lab, and you might consider your options differently then.
So I have one last question. It's for Dana. And Dana, I want to know, what do you think was the most helpful intervention that you did, or the healthcare workers? And can you tell us what was maybe your most inspirational moment over there that you think you made a difference?
Sure. So, it's really hard to say, and I've heard that, kind of the preliminary analysis of a lot of the kind of basic supportive interventions show that perhaps no particular one made a huge difference, but I think the final analysis is nowhere near done yet. But personally, I think I saw kind of the best turnaround with a lot of IV fluids. I think that's what we kind of were most aggressive with, and you saw some people who were pretty sick, turn around. Whether they would have done that without the fluids, who knows? It's really hard to know. But I think that's perhaps our most helpful intervention. And then I guess the most inspirational moment. We had this little girl who she had confirmed Ebola, and she was in our confirmed ward for weeks, and was encephalopathic, essentially comatose at one point. We were moving towards palliative care. We were considering palliative care in her. We didn't, end up ultimately doing that, but we kept going with a lot of supportive care, trying to feed her, giving her she began seizing, giving her anti-seizure meds. Just things did not look like they were going well. But she survived and ultimately, stopped having kind of the wet symptoms of diarrhea and that sort of thing. So we ran another Ebola PCR and she was negative. So she'd cleared her Ebola but remained very confused, lethargic. So we sent her, now she didn't have Ebola anymore, so we sent her to a nearby government hospital for ongoing, management. She was still not in a state where she could go home. She couldn't feed herself or anything like that. But, with ongoing good care at the government hospital, she kept getting anti-epileptic meds. She actually recovered completely almost. She was able to walk around, get up, feed herself. She was like kicking a soccer ball around, and that, like her in particular, I really feel confident that if we hadn't been so aggressive in our care, I don't think she would have made it. So it was really cool. Like I feel like she's a clear success that we can point to and feel good about. So. Yeah.
All right, well, let's thank the panelists. This has been really good. Thank you so much. Really appreciate it.